Dear all, welcome to the 13th edition of TMC Medalog. Today we have another distinguished alumni from Tanjore Medical College, Dr.V.G. Vinod MD DNB MRCP, an interventional pulmonologist, and he is an associate professor in Sri Ramachandra Institute of Research at Porur, Chennai, and he has about 12 years of experience in his specialty and 10 years of teaching experience, and he has several publications to his credit, about 25 or so. So today he's going to give us a talk on diffuse cystic lung diseases, and today it's going to be a really interesting a talk, especially for the first time we are going to talk, apart from a generalized topic, we are going to take in something which is very specific for the first time in Teams Medalog. So without much ado, I welcome Dr. Vinod to deliver the 13th TMC Medalog for us. The floor is yours, Dr. Vinod.
Yes, sir. Am I audible, sir?
Yes.
Yes, sir. Thank you for giving me the opportunity, sir. It's a privilege to talk in this forum. My interest particularly is in interstitial lung disease, where apart from the regular interstitial lung disease, I'm very interested in doing the pattern recognition in HRCT thorax. So with that, I came across certain patients where cystic lung disease alone had become a little more fascinating and very interesting to pick out the patterns, and a little more treatable. And there is a management difference apart from the regular interstitial lung disease. So I wanted to share some details regarding that. So next slide. Yes, sir. So regarding introduction, it is classified as it's classified as one of the interstitial lung diseases, but strictly doesn't fit into a regular interstitial lung disease. Still, for research purposes and for management purposes, and it has been grouped under interstitial lung disease, but it has been raised in many forums to be separated from the ILDs. It's a group of diseases, heterogeneous group of diseases. We'll be talking in detail about each diseases. The more interesting part is it will be hiding in the plain sight. That's the most interesting thing. There are many patients who've been just disregarded as an emphysema or some cavitary lung disease or pulmonary tuberculosis or old TB sequelae, something like that. And so beyond that terminology or description by the radiologist, then it becomes almost not an interesting part for many clinicians. So I'll share more images and other things. So they commonly share a phenotype of presenting as diffuse cyst, more than 10 cysts in the bilateral lung parenchyma. That's the common features of the diffuse lung cystic lung diseases. Next slide. So coming to the definition of cysts, so the Fleischner Society has given the very clear definition. Though it's easy for a radiologist to sit and see in the packs and mark out many things, I usually go to a radiologist and discuss with them about any kind of a doubt, whether it's a cyst or a mimicker of cyst or a cavity. If there is any kind of a pattern that I can pick up, saying it's a diffuse lung disease, then I'll go to a radiologist, where definitely it will help. The definition by the society is less than 2 millimeter thin wall should be appreciable. It should not be thick as a cavity. It should not be non-discernible like an emphysema. So in between is a thin-walled, air-filled opacity that is surrounded by a normal lung. So that's another important part of the definition. So next slide. So in that, how much is normal? So when we see, there are occasions where randomly we can see few cysts in a patient due to some early disease, or it's not, it's subclinical disease process, or because of aging itself in elderlies. We can have up to 4 cysts is considered non-pathogenic as such. So when you see more than 4 cysts, then you have to see whether it is polycystic or multicystic. So polycystic again is less than 10 cysts. It's considered polycystic, where the chance of a clear-cut diagnosis might not be there, whereas multicystic disease are usually prone to disease progression and are considered to be evaluated further. That definitely has to be evaluated, whereas polycystic has a limited set of differentials. Still, we need to have a closer follow-up for the patient if they are incidentally diagnosed. Yes, sir. Next slide. So then the point that I had already mentioned, whether it's really an interstitial lung disease or not an interstitial lung disease. So it's coming to that umbrella term, like ILD, it is stamped as ILD, but still when you take the demography, it affects more of younger age group people compared to the ILDs. When you see ILD, usually the patient will be in 50s or 60s commonly. So this cystic lung diseases usually tend to be in 20s, 30s, or in their 40s. So, and they often come with recurrent spontaneous pneumothoraces. That again it can become life-threatening, one thing. Second, the patient has to be aware about the complication of pneumothorax. So that makes it little different from a regular ILD, where emphysema is more prone to pneumothorax, whereas ILD generally will not be unless there is a suprared infection or other disease process like malignancy. And coming to the etiopathogenesis also, there are even neoplastic entity divided, subgrouped into the DCLDs, whereas most of the fibrotic ILDs are something like an external factor, something like an autoimmune process or an airway exposure, airway-centered fibrosis, like a hypersensitive pneumonitis. Everything is extrinsic or something which is separate, little different from the pathogenesis that we see in cystic lung disease. And when we have this terminology, when we group it separately as cystic lung disease, there are definite role for a targeted therapy, and prognostication can be better compared to the fibrotic ILDs, which usually we see between 5 to 7 years of in advanced fibrotic ILDs. Whereas even if it diffuse cystic lung disease, they have a better prognosis. It can be contained with targeted therapies. So that's the difference. So I think in the future, probably next 5 to 10 years, it will be separated as a different entity apart from the regular interstitial lung disease. Next slide, sir. So this is the entire whole spectrum of classifications, starting from neoplastic, which is lymphangioliomyomatosis, and pulmonary Langerhans histiocytosis. And some cystic metastasis can also be there. Genetic causes commonly is Bird-Hogg-Dubé syndrome, and some lymphoproliferative disorders grouped under this are commonly seen are follicular bronchiolitis and lymphoid interstitial pneumonia. But this has been combined as a single entity. So even the experts in the field, they would not be able to differentiate exactly which patient has follicular bronchiolitis and which patient has LIP. So they now the terminology used is FB bar LIP, which is follicular bronchiolitis / lymphoid interstitial pneumonia, which is a combination of term. And infectious, there are a lot of infection which can cause a cavity disease sometimes, and sometimes they can be an air trapping which can present as nematoceles. So most of Pneumocystis jirovecii infection, staphylococcal pneumonia will have a specific entity called nematoceles, and which is something very close to cystic lung disease. And associated with any other ILDs having cyst is hypersensitive pneumonitis, which is very prevalent in India. And then smoking related, I had seen both PLCH and desquamative interstitial pneumonia. Miscellaneous disease, or mostly traumatic patients, we see a lot of findings like pneumotocele or contusion or a pseudocavity. In that, it can mimic multiple areas, can have resolving consolidation, also can become little cystic. And mimics of cystic lung disease is very important, because the first step in diagnosing a cystic lung disease is to exclude the mimickers. Like, we should be very clear. I even suspected Bird-Hogg-Dubé in one patient where finally the gene mutation was negative. So the radiology was suspicious there were bilateral bullous lesions in a non-smoker. So I was more interested in ruling out the Burke-Hogg-Dubé syndrome. But ultimately, the radiologist also suggested is more towards emphysema and bronchiectasis. Cystic bronchitis has to be separated from this. And honeycombing, which we see in a lot of fibrotic ILDs, has to be differentiated from the cystic lung diseases. Next slides. So when we come to working up of the patient, this I just give you a brief about the overview, and then we'll go to each entity and the stepwise management, and then the four most commonly diagnosed cystic lung disease I'll go through. So with history and exam, there are certain, like for example, if you see LAM, which will be very commonly seen in female, it's almost a diagnosis of female gender. So that is an important thing. Sjogren syndrome, again, autoimmune disease is more common in female. Coming to age, PLCH, that is the Langerhans histiocytosis, will be younger age, and most of the diseases are in the younger age group. So, but all these things cannot 100% tell you the diagnosis. Many times it will be very difficult to differentiate between an LIP and LAM with just a radiology and the sex and age. So we need to get sometimes even a surgical lung biopsy to understand the diagnosis. Again, smoking is very commonly related to Langerhans cell histiocytosis. It should be there for the diagnosis. Sorry. So next slide. And when you go for systems review, it can give you some clues. For example, if patient has dry mouth, dry eyes, and other things, it can suggest the diagnosis can be LIP if there are cysts in the lungs. And if there are family history, there are 2-3 people in the family has similar lung disease showing lung cysts, then it's very highly suggestive of Burke-Hogg-Dubé disease. Again, dermatological lesion, there is fibrofolliculomas. Obviously, we can think of BHD. When we come to LAM, we can have sporadic LAM or a syndromic LAM. Syndromic LAM comes with tuberous sclerosis, where there will be facial angiofibromas, subungual fibromas. All these lesions can be found out in the skin and Sjogren patches, all those things. Sometimes these things can be overseen, and just the cystic lung disease could be the initial thing that would give us the idea about the underlying disease pathology. Next slides. So coming to lab investigations, again, we need to rule out certain mimickers, like for example, emphysema due to alpha-1 antitrypsin deficiency can be a mimicker. So that has to be ruled out. Again, connective tissue disease can be ruled out with ANA and extended profile. Immunodeficiencies sometimes can be associated with LIP. So that again, abnormal immunoglobulin levels will give us the diagnosis. Light chain deposition disease is one important differential diagnosis when we see cyst with internal septations. So that is very classical for light chain deposition disease. Again, there are certain diseases like LAM has very clear elevated VEGF levels. Again, this is not available in India, and we suspect LAM, and the patient is not fit for the surgical biopsy to prove it. Then we can send this. Is not available in India. This sample has to be sent to US or UK to get the levels, and the levels more than the 800 cutoff is diagnostic for the disease without the biopsy. Next slide. So coming to CT thorax, this is the most important thing that would get us the diagnosis. But the caveats are it should be a thin slice, high resolution CT. Before we read the CT, we should be very clear that the resolution is high resolution to understand, because sometimes there will be very subtle cysts. Even in high resolution, many radiologists try to get a minimum intensity projection to see the low attenuated areas. So that will help us to understand. Sometimes it can be missed if there is a pneumothorax. So again, once you put an ICD, when the lung expands, you redo a CT thorax. So you'll be able to identify if there is any cyst that was there in the collapsed lung. Again, you have to see multiple planes, because some planes can tell a very clear identification of the zones, involvement of the zones, and sometimes the vessel like I said, there can be a clue of vessel crossing the cyst or interseptation, which might be present in axial cuts, but that may not be there in the coronal and sagittal cuts. So looking at all the angles will tell us exactly certain clues about the distribution and the architecture of the cyst, individual cyst, which will help us in understanding the diagnosis. Like, for example, perivascular cyst is very classical for Birt-Hogg-Dubé disease. So, we'll come to all the images that I've put in the presentation. So contrast imaging is not needed. So unless we suspect a malignancy apart from the cystic lung disease, if there is a coexisting lung mass or a nodule, then probably we need contrast imaging. So first step in approaching a cystic lung disease, you see a CT thorax, and if there are bilateral cysts, in the first step in bilateral air-contained cavities or air-contained areas, low attenuated areas, the first thing is to ask the question whether it's really a true cyst. So in that, the location and the appearance can help us in diagnosing whether it's really true cyst or is there an emphysema. So emphysema usually will be in centrilobular location and will not be having any distinct walls. And there will be associated, there can be a bulla somewhere else, and it will be bilateral diffuse involvement also. Cystic bronchiectasis is another mimic. Honeycombing is already mentioned. Honeycombing and cavities are all the gas-filled spaces that can develop in a focal consolidation or a mass. So these mimics can be easily diagnosed with multiple planes that we see in the HRCT, like axial, coronal, sagittal. Everything can be evaluated, and then we can come to the conclusion. I've put the images also. Next slide, sir. For example, these are the images that are mimics. In this, the panel A, you can see a lot of fibrotic areas. And along with that fibrotic areas, you can see gas-filled spaces. So this is suggestive of an interstitial lung disease, pulmonary fibrosis, and honeycombing. So when you come to the panel B, there is a lung cavity. We can call this cavity because there is a thick wall. So that it cannot be a cyst, because the definition itself should be very thin walled, 2 millimeter wall. And panel C, it shows when you see probably in a PAX, you'll be able to understand the bronchus will be leading into the cystic dilated areas. So continuity of the airway can be seen in continuous slides. So always better to not see the images in CT film. You have to go and sit in the PAX. And in the PAX also, you should open the high resolution cuts. When they have a shorter panel of slides, where there'll be only 50 or 60 slides, there'll be 500 or 400 thin cuts sections will be there. So where it can help you understand it better. And coming to panel D, there is subtle emphysema. You can see the cyst airfill spaces, but there is no wall. There is no white ring-like thing that differentiates from the lung separately from the lung parenchyma. So this is a central lobular emphysema. So once we rule this out, then probably we'll be able to understand. Definitely, we are dealing with a cyst. Next slide, sir. So next, when we see then how many cysts are there, that should be the things. Again, here, if we do not a thin cut regular CT, we might miss out interval areas where there can be a few cysts missed out. So that will make the difference between the management. When there is less than 10 cysts, less than 4 is even not considered as a disease. So when there's between 4 to 10, it can either be age-related, can be congenital, can be pneumococcal, can be parasitic infection. We hardly see any such disease so far in my practice. Can be cystic lung cancer. One patient with scalp malignancy had bilateral cysts. So this is a possibility. Again, the patient present with bilateral pneumothorax, there was a targeted therapy also, which had 3% incidence of pneumothorax. So there are a lot of factors in that patient, but still the suspicion was it could be a cystic metastasis. We couldn't prove because the patient was not very well to get a lung biopsy. And this less than 10 number can be a harbinger of a future disease. So all these patients had to have regular serial lung functions to see for any decline in lung function. And we need to see serial chest imaging also. Next slide. So coming to the more than 10 cysts, then what we have to see is if there are multicystic disease. So this becomes multicystic disease, then it is typical of DCLD, diffuse cystic lung disease, what we see in our practice. So there, as I told you already, history, exam, lab can give you some clues. But more important thing in the CT thorax is, the next slide, sir. We need to see for additional findings. So if there are no additional findings, then more likely the diagnosis is either lymphangioliomyomatosis or Birt-Hogg-Dubé syndrome. So these things usually will not have any accessory findings apart from the cyst. It will be only isolated cystic lung disease. So in this, there is one other differential, couple of other differentials. Maybe very rarely even LIP, lymphoid interstitial pneumonia, also can be without any added findings, but usually it has ground glass opacities or fibrotic lesions along with the cysts. Or cystic metastasis, like I said, can have a little more cyst also at times, but usually that will be polycystic. So the differential for an isolated cystic lung disease without any additional high resolution CT findings are LAM BHD and lymphoid interstitial pneumonia. The next slide, sir. So when you come to next step, so there is some additional findings apart from the lung cyst. You're able to see something more. Then you have to find out what more we are seeing. So if it is only ground glassing we are seeing apart from the lung cyst, then the more important thing is to consider is the pneumocystic infection. And if you think of pneumocystic infection, then you have to work out the underlying immunodeficiency disease also. Second is if the patient is a smoker and very classical with heavy higher pack years, then you have to think about declamative interstitial pneumonia. Third is if there is some autoimmune features of the female in sex, then probably lymphoid interstitial pneumonia is the other differential for patients with multiple cysts, more than 10, with ground glass opacities. So when you come to the other stem, when there is isolated, when there is cystic lung disease with additional nodules, then the differential goes towards either Langerhans histiocytosis, amyloidosis. Very rarely it can be LIP or a light chain disease, deposition disease. So more common is Langerhans histiocytosis and amyloid in this stem, in nodules on. Next slide. So these are the four major reasons. So coming to clinical, so when you see in the practice, only 4 things are very commonly seen in this entire thing. Other things are probably rare. Probably we'll be seeing 1 or 2 patients in our practice. So while these things are very common, I've seen at least 10 patients of BHD, at least 5 patients of LAM. LIP we have suspected in many patients, but only few turned out to be very classical, the autoimmune panel negative, positive, like a syndromic presentation. Whereas the fourth panel PLCH is little less in my practice. I've not seen much. We've suspected in 1 patient, but the problem is getting a lung tissue for confirmation of the diagnosis. That again will be a difficulty. So when you see the panel A, you can see it's diffuse cyst bilaterally, and the size is almost small and uniform, rounded uniform cyst. So that's characteristic of lymphangioliomyomatosis. And the same panel A in the lower image, in the third image, you can see it is diffusely distributed. It's distributed in the upper and lower zones everywhere. So coming to panel B, so that panel B is suggestive of Birt-Hogg-Dubé syndrome, where there is characteristic paramediastinal cyst and perivascular cyst, and it is lower lobe predominant. So when you see the third image of the panel B, you can see grouping of all the cysts in the lower lobes. So that's very characteristic of Birt-Hogg-Dubé disease. And coming to panel C, there is lymphoid interstitial pneumonia. So this is little common again in the practice. where we sometimes say with this countable cyst, when you can count it, so and it's uniform, it's more likely to be LIPs. It's what the general teaching dictum in our practice, and you can see it is also randomly distributed bilaterally throughout. There is no lobar predominance, zonal predominance. When you come to panel D, that is the Langerhans cell histiocytosis. That can have bizarre shaped cyst, that can have nodules, but the predilection will be more towards the upper zones. So when experts talk about this, there is a way of approach where you can divide the lung into upper and lower zones. If the lower zone predominant, you can suspect first Birdhoff-Dubé disease and think about that, get a family history, work out with a genetic study, see for paramediastinal cyst, look for perivascular cyst, all those things. When you see upper lobe cyst and a smoker, young male, then you tend to think of PLCH. There is both involvement of upper and lower, then you can think of LAM and LIP. So this is how the approach sometimes suggested by the experts in this DCLDs. Next slide. So I'll just brief about each separate diseases. Lymphangioliomyomatosis again can present with dyspnea, pneumothorax, chylothorax. Cyst feature, as I told you, will be round, thin-walled, uniform size and shape. When you come to distribution, this is diffuse. There is no zonal predominance. I mentioned already. It's more common in females and typically diagnosed in reproductive age group. And there is a concept of this becoming almost static or stabilized without any progression once they cross the menopause. So more likely, so when we see a patient with elderly like 50s or 60s, then we tend to be less aggressive in treating them. We'll observe the patient. We'll tend to monitor them rather than going for any invasive procedure or any diagnosis and see if they're progressing or see really how's their radiology and pulmonary function test. So it can be sporadic and it can be along with a tuberous sclerosis disease syndrome also. Next slide. So this is the classical CT thorax. You can see diffuse, rounded. You can see very clearly around circle areas of gas-filled spaces, and it's diffuse. So this is a very typical image of LAM. So next slide. So can you click, sir? It's a video. I try to share a video.
It's not playing, Dr. Vinod.
Double click, sir. I tried a couple of times. It worked.
Maybe when I'm sharing, it's.
Oh, it got lost. Okay. Okay, sir. No problem. It's again a video of cystic lung disease of a LAM patient. So no problems. So next slide. So when we need to see the other systems manifestations also, especially when you suspect LAM or you diagnose LAM, then you look out for see for any abdominal pathology or a dermatological pathology to put it in a syndromic disease, where then you have to screen the other patient, you have to give genetic counseling, and all those things can be family clusters, and they can have other tumors somewhere. So this definitely matters when we see a patient. That video which was not playing was only having 4-5 cysts in the bilateral lung fields, and there were nodules also. But it's one of the patients of my colleague. So sir went ahead and did a lung biopsy, open lung biopsy, batch biopsy, where it showed the diagnostic confirmation. HMB45 was positive, and then we were thinking about working up for the other involvement, doing a brain imaging and doing a dermatological survey, abdominal imaging. That was not discussed before because we ended up losing the patient after the follow-up. So once we get a diagnosis of LAM, that doesn't stop there. Usually LAM will have only isolated cystic disease. If there is cyst with a lung nodule, then probably once you confirm that it is a LAM, then you have to think of a syndromic diagnosis like a tuberous sclerosis. So next slide. So diagnostic clues again, The patient can have chylothorax, can have lymphangioliomyoma, can have renal AML, cyst plus all these things can very characteristically can be syndromes. For diagnosis itself, the patient is not willing for or fit for biopsy, then you can do this VGFD levels. If it's more than 800, then lung biopsy is not needed. If it's elevated, then it can be taken up as a diagnostic marker along with a typical radiology. So next slide. So complication, when we talk about LAM, it can cause recurrent pneumothoraxes, spontaneous pneumothorax. It can cause progressive respiratory failure can happen. So that's the importance of getting the diagnosis. Just leaving the diagnosis, patient might progress towards respiratory failure rather than a simple cyst disease. It can gradually progress to have respiratory failure with more and more parenchymal involvement. And there is a target therapy available that will come to this. Next slide, sir. Yes, so we have mTOR inhibitors, which is very effective in stabilizing the disease for moderate to severe disease or progressive lung disease, or when there is a recurrent chylothorax or large AMLs. Then we usually suggest to start mTOR. We give sirolimus, and everolimus also is being tried. Sirolimus has some side effects of delayed wound healing, gastric intolerance, other things. But there are studies going on for low dose sirolimus at least to prevent progression of the disease and decrease the side effects also. And when we see such patients, a cystic lung disease, when the first pneumothorax happen itself, we'll go ahead with the pleurodesis. And pleurodesis previously was considered as a contraindication for lung transplantation, but now it's not considered anymore. So lung transplantation, if the patient even undergoes a pleurodesis, we can later on, if the patient progresses, we can subject them for a lung transplantation also. Next slide. So coming to the next entity, the Bird-Hogg-Dubé syndrome, it again presents most commonly with spontaneous pneumothorax. The one better thing about this is it is little slowly progressive compared to LAM. This is little slowly progressive, and we have time to diagnose it and control it and treat the patient also. The only thing is this is a very underdiagnosed entity. After coming to this institution, I've seen almost 10 patients where it was not suspected initially by the radiologist or the physician, but then gradually as I see more and more patients, we tend to see through the issues that happens in the radiology. So cyst features are, it has variable size. That's the problem with this. It doesn't have a uniform cyst like LAM. Variable size will be large cysts. I'll show you the images also. Something like a bullous lung disease also. So it will be, if the patient is a smoker, then easily it can be like washed off as an emphysema or bullous lung disease. So there will be round to elliptical cyst and lentiform. Biconvex cyst is very characteristic of it. And distribution is its peripheral and basal predominant, and sometimes it can be peculiarly subpleural also, and perivascular is very characteristic. So next slide. So when you see this is one of my patients. It's yet to have the diagnosis. It came to me with a suspected right-sided pneumothorax. Even this was discussed with radiologists. The lower lobe area, it's even now suspected to have a pneumothorax. But other than this, you can see a large bullous-like lesion on the right side. You can see in the left side also the large cyst. Apart from that, there are bilateral cysts also in the left side. And the one more important thing here is peculiar thing is the lower lobe area. I can see almost the cyst floating in the air, like cyst within cyst type also. You can, when we closely see, it's just cyst attached to a thin septa of collapsed lung, thin strand of collapsed lung. So these are very classical and typical picture that can be seen in Bird-Hogg-Dubé disease. This is a female patient who came to me with progressive breathlessness for the last 6 months. She was diagnosed with some kind of cystic lung disease 10 years back in CMC Vellore, but she didn't have that images. So this was pending bullectomy. We have referred to surgeons and pending a genetic testing. This is a radiologically diagnosed one. Next slide, sir. So again, female and male are most equal in this. There will be positive history sometimes, and family history of pneumothorax can be there. Skin lesions can be there. Renal tumors can be there. And FCLN gene mutation will be a pathognomonic thing. Either you do a biopsy and prove it is fibrofolliculoma, skin biopsy, or you do a gene mutation. Either this or that will be a confirmatory diagnosis. And one more important point is this can be a lung isolated disease also. Sometimes there won't be any skin lesions, there won't be any renal tumors. There will be only isolated lung lesion. That again will be precluding us to put the diagnosis. But it is in our forum, in our society, pulmonology society forum, at least once in 6 months we come across some CT, which the patient doesn't have any other skin or renal issues, but the radiology is very classical, and few has turned out to be genetically confirmed also. So that again, form of rest manifestation is very common in Birt-Hogg-Dubé disease. Next slide. So again, as I said, renal tumors and skin fibrofolliculomas can give us a clue for the diagnosis. Next slide. So skin biopsy or gene mutation studies, either one is enough for diagnostic confirmation. The next. So complication, why we need to diagnose this and separate it from other disease, why need to confirm is we need to have at least, I think, 2 years once we need to do an abdominal imaging, an MRI, to have from the age of almost 35 it has been recommended. So what I remember for a renal cancer. So it is an important diagnosis to make, and we have to counsel the family also. There can be some lung disease in the family members which would have not been diagnosed. So again, that has to be counseled. There should be genetic counseling and family counseling to be made. And the patient can have recurrent spontaneous pneumothorax. So they have to be well counseled about the symptoms about pneumothorax, how to manage it, how to immediately go to a nearby center for getting the diagnosis, confirming the diagnosis of pneumothorax and get a ICD run or a drainage promptly. Otherwise, they can have tension pneumothorax and can lose life. So they need to be taught about risk of pneumothorax, and they need to avoid certain activities like air flight is again is advisable, but scuba diving is not recommended for them. So all the even work related advice also has to be given to them, and genetic and the malignancy screening also is important for the patients. Next slide. So coming to management, so early pleurodesis for any pneumothorax, early pleurodesis has to be done. Longitudinal screening of family, renal cancer is important, and family screening are important. So these are the essential considerations that we give. Even there are studies which are trying mTOR inhibitors for this disease also, because this again is considered to be involved. This is then considered to have that mTOR pathway involved in this pathogenesis also. And one more thing is, apart from regular surgery for bullectomies or pleurodesis, ICD pleurodesis, we have even there are centers doing total pleural covering with some kind of mesh to prevent further pneumothoraces. So that is tried in LAM, and now that has been extended to even Birt-Hogg-Dubé disease. So total pleural covering is one very advanced management that can prevent pneumothoraces for cystic lung disease. In Birt-Hogg-Dubé disease, they don't generally talk about transplantation like LAM because this is very slowly progressive. That is the only favorable thing for Birt-Hogg-Dubé disease. Next slide. So coming to PLCH, again, Langerhans histiocytosis, they present with cough, dyspnea, chest pain, pneumothorax. Cystic, the features of cyst will be variable size, and there will be a lot of bizarre shaped cyst. There can be even something called octopus sign, where there will be cyst and with internal strands can connect the central pulmonary vasculature to the periphery of the cyst. So, so the bizarre shaped cyst, upper zone predominance. So all these things can suggest it could be LAM and PLCH, and along with the smoking history. And it will spare the costophrenic angles. That's a uniqueness of this PLCH. And there'll be nodules. When you see there'll be nodules, and sometimes there can be fibrosis also if it is advanced disease. So that's the essential progression of the disease. Initially, there'll be nodule formation because of the Langerhans cells, and then gradually the nodule will expand and cavitate and become a cyst. So that's the pathogenesis given. So if it is an advanced, far advanced disease, only we'll be able to see cyst. If it's a midway disease, we can see both cyst and nodules. If it's a very early disease, we might see only nodules sometimes. Next slide. So this is a classical CT where you can see bilateral, almost like an emphysematous disease. We're not able to very clearly see sometimes some areas, the wall and everything. But this is a proven PLCH, and there is left-sided pneumothorax also, for which ICD is in situ. Next slide. And both male and female are equal, but in India it's more male predominant because smoking is more common in men here. And BRAF and other MAPK pathways mutation are considered to be the pathogenetic mechanisms, and typically diagnosed in 20 to 40 years of age. They can have lytic bone lesions. They can have diabetes insipidus because of the Langerhans cells sometimes can cause disseminated disease. Next slide, sir. You come to diagnosis again. We need CD1A and CD207 cell aggregates. Often, getting a lung biopsy is the difficult part because patient may not be fit. Maybe in respiratory failure, where surgical biopsy is not advisable. And any cystic lung disease, bronchoscopic biopsy will not have the adequacy because the entire cyst has to be seen. So the lung biopsy, even bronchoscopic cryobiopsy also is not enough. When you take samples from a surgical perspective, you'll be able to take an entire cyst. You can see the characteristic of associated lung, and the pericystic changes also will be better. And here, sequencing of MAPK pathway mutations also can help in diagnosis. Next slide. Coming to complications, this again, similar to LAM, can have multiple episodes of recurrent pneumothorax can happen. Progressive respiratory failure is very important, and pulmonary hypertension. So we'll be having something very similar complications to lymphangioliomyomatosis. Next slide. And management of smoking, we have to advise very strict smoking cessation. Serially, we have to monitor lung function, give bronchodilators if there is any kind of airflow obstruction along with the cyst. And BRAF and MEK inhibitors, there are a lot of Durafinib. So a lot of targeted therapies are available. But efficacy-wise, it's not very clear about which patient can respond. So cladribine is another agent that can be used for controlling the disease progression. Next slide. So the last entity of the four, coming to the follicular bronchiolitis and LIP, as I said, these two things are considered together now. The radiologists are talking as a single entity because it's considered as a spectrum of disease rather than separate entities. So again, patient can present with cough, dyspnea, but this pneumothorax chance is less because the number of cysts are less, and it will be more in the perivascular area rather than subpleural, what we see in BHD, LAM, and PLCH, where it can extend to the pleura. Mostly here, the chance of pneumothorax is less. And smooth, round, thin wall cavity of variable size also can be there. This also can have internal septations. And distribution-wise, it will be slightly low predominant, but it can happen diffusely in all areas. Yes. So this is classical image of LIP, but here you can see there is a subpleural cyst, which is little. There are a couple of subpleural cysts which is little difficult to differentiate, and there can be a cyst with internal septations also. Here you can again see this countable cyst in this image. Again, you have to go through the entire imaging. It's low predominant. When it is low predominant, the easy way to do is how to differentiate it from Birt-Hogg-Dubé diseases. There is two paramedian cysts that can tell, more than two paramedian cysts can tell us whether it's LIP or BHD. And a larger cyst spanning from mediastinum to the pleura can again say, suggest towards Birt-Hogg-Dubé disease. Next slide. So this is the algorithm for isolated cystic lung disease, where LIP, LAM, and Birt-Hogg-Dubé sometimes will be very difficult to differentiate. So first question we'll ask is the distribution diffuse or lower lobe predominant? But is diffuse always is LAM, Then you can see if the patient is male, the diagnosis of LAM is unlikely, or we are not sure. Then we have to do a surgical biopsy and understand what is the cause, or we have to look for other differentials. If this low predominant, then you have to look for either more than two paramedicinal cysts, or disproportionately large paramedicinal cysts, or disproportionately more paramedicinal cysts. Those suggest Birt-Hogg-Dubé disease. If it is not, then again is indeterminate. Then LIP is favored. Either you accept that and evaluate for it, or you need certain more aggressive investigations for diagnosing the underlying disease. Next slide. So again, for LIP, the diagnostic clue is more in female. There will be some kind of autoimmune disease or immunodeficiency disease can be there that can suggest it's more towards LIP. Again, there can be associated Zika symptoms, arthralgias, Raynaud's, and there can be some kind of infections, past history of infections that can suggest it can be immunodeficiency syndrome. Next slide. So again, we need to do the appropriate serologies, appropriate autoimmune workup for the diagnosis. Very rarely, we need to go for lung biopsy to differentiate between the diffuse cystic lung disease. Next slide. So the complication, again, LIP can progress towards respiratory failure. They can be rarely pneumothorax. One more important thing is transformation to a lymphoma is very important thing when we consider LIP. So in case the patient comes with some kind of generalized disease process, I've seen at least a couple of rheumatoid arthritis patient suddenly coming with a large effusion or pericardial effusion, pleural effusion, which again rapidly worsen towards the respiratory failure. Next slide. So management-wise, for LIP, we need to serially monitor the lung function, treat the underlying disease. That should be the main issue, because LIP is rather a disease, is a manifestation of underlying immunodeficiency or autoimmune process. Next slide. So there are certain signs, peculiar thing that we'll share. This is an air cuff sign. You can see the cyst engulfing the bronchovascular bundle. So this is considered an air cuff sign. If we see this, we can be pretty sure that it's suggestive of a Birt-Hogg-Dubé disease. Next slide. So again, irregularly shaped paramediastinal. You can see the cyst paramediastinally, and it is causing indentation of the mediastinal fat. So when this kind of character is noted, then again we can say it can be Birt-Hogg-Dubé disease. Next slide. Again, subpleural, you can see the previous image we saw about LIP also had subpleural cyst, but here you can see it's very large, almost spanning from the cardium to the pleura. So such a large cyst, and on the other side also you can see it's not rounded, it's very bizarre shaped, a large cyst noted in the right lower zone also, lower lobe also. So again, such characters will tell us more towards Birt-Hogg-Dubé disease. Next, please. And coming to general recommendation, apart from all the specific management we spoke about, general recommendation that we need to avoid them. We need to counsel them to stop smoking if at all they are smokers. We need to advise them to vaccinate, because any kind of superadded infection can worsen, precipitate respiratory failure, can worsen the cystic lung disease, can make it a progressive respiratory failure, or there's a chance that they can go for a pneumothorax also because of a secondary infection. So all of them should be vaccinated. They should be educated about pneumothorax because the life-threatening episodes, life-threatening manifestation. So, and they need to have, if they're from a remote area, they need to definitely be counseled about early seeking of healthcare rather than waiting for a couple of days for some over-the-counter medications. And the risk of in-flight pneumothorax is very, very less. Air travel is considered safe for most patients, but still it depends on case-to-case basis. If they had a recent pneumothorax, definitely is not advisable for them to fly for at least 2 weeks. But generally, we'll tell them not to fly for 4 to 6 weeks. Again, scuba diving is more riskier, so they're advised not to go for any kind of activities like scuba diving or underwater activities. And patient presenting with pneumothorax should be pleural disease. We not wait for any pneumothorax for any other disease. Primary spontaneous pneumothorax, usually we wait for second episode for pleural disease. Here, we don't wait for it. Any episode of pneumothorax, we do drainage, and then same sitting itself, we do pleural disease, and it's not a contraindication for a future lung transplantation. Next, please. So from these a few years of cystic lung disease experience, my lessons is it's very grossly underdiagnosed, and it can have atypical presentation and partial presentation, form of manifestations, especially in Burnt disease. And if LAM is diagnosed, we need to look for underlying tuberous sclerosis syndrome also. TB, I didn't speak about TB. TB is one important differential. If the patient comes with fever, loss of weight, loss of appetite, even if the CT shows cystic lung disease, diffuse cyst, we had one patient where by the time the patient expired, by the time we got the diagnosis, the patient expired because we went into respiratory failure. We were not sure whether it's autoimmune disease or anything. Then finally bronchoscopy was done. And the post bronchoscopy, the patient had worsening respiratory failure, could not be managed. And then the gene expert turned out to be positive. So TB has to be an important differentiation, especially in diffuse cystic lung disease. And in patient with pneumothorax, lung cysts can be missed. So we look at only one of the lung, which is normal, and we may think it's not a cystic lung disease. Once the lung expands on the pneumothorax side, we may be able to appreciate the bilateral extent of the nature. And the flow chart, usually we have for cystic lung disease, the stepwise approach that I mentioned, step 1, 2, 3, 4. It's for guidance, and sometimes there can be overlap of either on either side. Like, for example, the patient can have isolated lung disease, who generally has to have some kind of additional findings, or it can be the other way. Sometimes LAM can come with additional findings also. So from these things, apart from this, I had a patient with chronic renal disease patient on dialysis, had bilateral cyst, where amyloidosis was considered. But again, the problem is coming to a diagnosis, we need a lung sample, which is very difficult at many point of time. So amyloid was suspected and discussed with radiologists, where again they said there are no other features of amyloid. There's no tracheobronchial amyloid, there's no tracheal thickening or any other radiological features to suggest. Again, I had a couple of patients of LIP where autoimmune workup was all things negative, so we couldn't get a lung biopsy. So again, the patient had pulmonary hypertension with lung cyst. We couldn't have a proper diagnosis. So lung biopsy becomes a crucial thing. And finally, one patient, we had respiratory papillomatosis that can have polyps, tracheal polyps and lung cysts with internal contents also. But there was no tracheobronchial polyps, and the lung cysts are very sparse, and we couldn't get a biopsy done. So we when we look at it, we often encounter this cystic lung disease. Definitely, when you are in practice, you'll be able to see at least few patients of diffuse cystic lung disease, where the diagnosis definitely will change the outlook for the patient, can have important implications in their management, in their future pneumothorax risk, or in family screening, in their malignancy screening also. Next slide. I think that's the end of the PPTs. Thank you, sir.
Thank you, Dr. Vinod. That was a wonderful presentation. We have taken 4 prototypical diseases of the cystic lung disease and gave us a real clear-cut account of what they are. And the radiological imagings were really helpful. So, I mean, the forum is open for audience to ask their questions or any comments. they can directly talk to Dr. Vinod. Can unmute yourselves and do that. So let me start the ball rolling. See, how commonly are you people doing whole exome sequencing for identifying genetic disorders, especially for bird heart, BHD, and the other entities that you're discussing in cystic lung diseases? How often it is used?
But whole genome sequencing, we don't use, sir.
Whole exome sequencing.
Sorry, yes, sir. Whole exome sequencing. I specifically asked for folliculin testing.
Okay.
So FLCN testing can be marked and given to the genetist for if you suspect. Usually they'll ask for the entire history and everything. And quite commonly we do that. We suspect Burthog Dubé, immediately we have our in-house genetic team also.
Okay.
And it can be sent outside also. There is outsourced. The sample is usually outsourced to some other lab here, and we get a report in 4 to 6 weeks.
So basically, targeted gene sequencing. Basically, you look for targeted genes which are a defect, because you know the phenotype. You are able to clearly look for specific genes.
Yes.
So, the post-COVID era, are there any significant rise in the post-infective cysts in the population? Have you noticed any significant increase in cystic lung disease?
Cystic lung disease as such, when we talk about these common entities, sir, post-infective picture will be not considered, sir. We don't consider, because the important thing about diffuse cystic lung disease is we're worried about the progression of the cyst. We're worried about pneumothorax, and we worried about some malignancy that might happen. So in a post-infective cyst, even there'll be a lot of post-infective bronchiectasis and a lot of post-infective something like emphysema or bullous disease that might happen sometimes. So those entities are usually, it's not very commonly seen there, but we don't think it as a progressive disease as such. So
my question is, after the COVID era, after COVID,
yes,
a lot of respiratory post-COVID fibrosis, and a lot of autoimmune diseases became, flaring up, especially different systems, renal disorders. We had a whole compendium of histopathological findings in vasculitis. So what kind of pathologies, unusual pathologies you're seeing after the pandemic? The cystic lung diseases.
We're more easily able to convince the patient to get a CT, sir. Probably that has helped us to look for a lot of patterns. So I don't have, probably I joined this institution in 2019. Before that, I was not very interested in cystic lung disease, so I'm not able to say before that was it less common and is being more and more picked up, or presentation is more. But the awareness, even in our society, when we discuss the HRCT, I used to discuss with a couple of colleagues in our forum. So where, because of their like knowledge sharing only, I had this interest in cystic lung disease, because they had seen a lot of such patients. So as such, pre and post COVID for cystic lung disease, I don't think as such it matters that much. For ILDs, we see ILDs, there's a lot of ILDs. Patient post-COVID, the persistent fibrosis, all these things, that is quite common. Autoimmune disease, we are picking up certain patients where they're saying post-vaccinations only, exactly after like 1 or 2 months after vaccination, COVID vaccination, they started having some myalgia, some kind of rheumatology symptoms, and then they was evaluated and diagnosed to have rheumatological disease. So we're not sure whether that had any implication underlying some cross reactivity triggering of occult autoimmune diseases.
Okay. So,
Dr. Vinod, this is Dr. Bose.
Yes,
see,
sir.
I had a small doubt. Like you see a lot of cysts in the lung commonly, but we don't start treating them. So
Yes.
when do you really start treating them? What is your indications to start a treatment when you see such cysts? Most of them are asymptomatic. They come to us just with a CT scan done for some other purpose, and they pick out these cysts.
Yes, sir.
When do you really start treating them, and what is your guidelines to start treatment?
Sir, for treatment, the patient has to be symptomatic, sir. For considering these 4 common things I'll talk about. So, for example, lymphoid interstitial pneumonia is a manifestation of the disease. So, we need to work up an underlying diagnosis. Based on the diagnosis, we'll be treating. For Birt-Hogg-Dubé disease, they don't recommend any kind of pharmacotherapy. It's only management of pneumothorax. We had a young female with a loculated pneumothorax. We didn't do anything. We just observed the patient, told the patient if there is any increased symptoms, should come to us, and avoid activities, exertion, any kind of gym activities or anything, unusual straining. And coming to PLCH, definitely upfront we need to treat, sir. PLCH and LAM also, we need to start treatment in the early years itself, so that they don't progress to that advanced disease. So PLCH and LAM are a little more concerning things. Birt-Hogg-Dubé is very, very slow progressing. Management only about pneumothorax. Fourth, the LIP is about underlying disease-based things. Like if it is HIV-related issues, then treatment for that. If it is autoimmune disease, then automatically the patient will go for some kind of immunomodulators or immunosuppressants.
So
Like that.
that means you need to evaluate every patient with a cyst and do a biopsy for everyone. Is it like that, or you base your decision based on?
Yes, sir. If the patient, for example, if the patient is very highly suspected to have LAM, definitely a biopsy, upfront biopsy and stamping it will be helpful, sir. Like, for example, the video I was trying to share was not playing, but that had a patient with some 5 or maximum 10 cysts in the bilateral lung fields, but the patient came with pneumothorax. So it was worked up, and even surgical lung biopsy was done because we didn't want to miss out any kind of odd presentation. One doubt was, could that be any malignancy? Because there were some nodules also. So there we had to do a surgical lung biopsy. Other than that, biopsy for every patient, it will be taken up case-to-case basis, sir. Like we need not.
Okay.
We tend to like to put it in a diagnostic basket as much as possible, so that we'll be able to understand how to monitor and manage them, rather than jumping and doing something upfront. We'll counsel the patient and try to make them understand that this kind of thing is important at that certain point of time.
Okay. Now, why I was asking you is, I think you would remember we had a patient with soft tissue sarcoma.
Yes, sir. Yes.
Who reported in Ramchandra with a cystic lesion in the lung.
Yes, sir.
And she presented with a pneumothorax.
Yes, sir.
And then the issue was, if you try to do such biopsies, would you land up in something like a bronchopleural fistula or something like that?
Yeah, yes, sir. So I remember that patient had bilateral pneumothorax, sir. I think it's
yeah. She had a pneumothorax, but it resolved and all. Right?
Yes, sir. Elderly female. So again, the diagnostic algorithm based thing, I tend to look at the patterns, pattern cyst features, and see if it is something can fit into a LAM, or for example, something into BHD. I'll aggressive workup. These 2 things are a little common in my practice. But that was an elderly female. When we think about what could be the possibilities, could be cystic metastasis, or it could be some kind of could be LAM also. Sometimes diffuse bilateral rounded cyst can be there, presenting in pneumothorax. So management of pneumothorax was done, but lung sampling may not be possible in her situation, but LAM will not be progressing after the reproductive age group.
Okay.
Even if we diagnose also, it's only for diagnostic purpose. Apart from that, we need to monitor the imaging. If there was old imaging, we can compare and understand if there's a malignancy patient would have been a PET before, and see if the cysts are increasing numbers. Will it be causing any more future issues?
Okay.
Yes, sir. So
Thank
based
you.
on each case, it will be a little difficult to have a blanket approach.
So you can decide based on the radiological finding whether to do a biopsy or not. Can I take
Yes,
it
sir.
like that, like the CT?
Yes, sir. Yes, sir.
Thank you, Vinod. Nice.
Thank you, sir.
So one more question in the chat box by Dr. Nandakumar. So he wants to know, in BHD, how common is fibrofolliculomas and how do you actually identify these lesions on clinical exam?
The clinical exam, I discussed with the dermatologist. I had a patient where that's a patient who presented with pneumothorax. Then ICD was done. Then the lung expanded. Then only we understood that. First time we missed out. Then after the expansion of pneumothorax, only understood there was bilateral cystic disease. Then I approached the dermatologist. Dermatologist said, no, it looks like very non-specific issue. But any kind of lesion, usually it will be in the facial or upper torso areas. It's better that we discuss with dermatologist upfront if there is a doubt about the lesion to get a biopsy. So two things. One, it's cheaper rather than the genetic study. And it proves it confirms the diagnosis of fibrofolliculoma, then we don't need any other thing. Any other genetic test or anything. So that is one of the disease-defining things, manifestation. So I always see for any kind of vague lesions also. So I discuss with my dermatologist, but in the forum and in our institution, the patients what we had, only 1/3 had some kind of skin manifestations.
Thank you, Dr.
So if there are any further questions, we can ask Dr. Vinod. If there are no further questions or comments, we can probably end the session. Okay, thank you, Dr. Vinod, once again for just giving useful information regarding cystic lung disease and the basic clinical approach to the common disorders which you have encountered. And it was nice having listened to your experience in managing these cases as well. So it's definitely illuminating because we tend to do a lot of CTs and most of the time we tend to miss. We see an occasional cyst in here and there, and then we write it off as emphysematous bulla or a cyst, and then we just forget about the whole pattern recognition on radiology and the subsequent clinical suspicion, especially respiratory failure and respiratory morbidities are increasingly very important entities in the non-communicable disease spectrum. So I think it's important that every clinician is aware of cystic lung disease in a way so that they can do what is right for them. Thank you once again. Thanks everyone for joining us. And in the November 16th, we'll be having our 14th session of TM's Medalog. And I'll be shortly posting about it in our WhatsApp forum. Thank you all, and thank you, Dr. Vinod. Have a great day. Stay safe.
Thank you, sir.
Thank you.
Good night.